Mood Disorders on this edition of Audio Digest Psychiatry, Volume 17, Number 12, for the week of June 20th, 1988. Beginning the hour, David L. Dunner with some advice on treating rapid cycling bipolar affective disorders.
Among the pure patients, the primary affective disorder patients, if you will, rapid cycling we defined as 4 or more episodes per year, and we define an episode as a high and a low and a high and a low. How prevalent is it? Certainly, if you were in a general psychiatric practice, my guess is that no more than 4 or 5% of all of your manic depressives are apt to be rapid cycling. If you consider this another way, rapid cycling among bipolar 2 patients is much more common than among bipolar 1s. The term bipolar disorder here, since you pretty much have to be hospitalized for mania or have a severe manic illness, really refers to bipolar 1, those who've been hospitalized for mania. In other words, those are patients who at one point in their history have had a severe manic episode. Bipolar 2s have recurrent depression in mild highs, and bipolar 1s have recurrent depression in severe highs. Now, if you find a patient who says, I have frequent depressions, ask them about mild ups at the tail end of their depression or the beginning of the depression. And you define the depression, say blue, sad, down the dumps, loss of interest, trouble concentrating. Say, when you come out of it, do you overshoot and do you have a week or two where you get up, high, elated, terrific, on top of the world, or just before the depression are you like that? And you're going to pick up your bipolar 2s by asking that kind of question. If you say, do you have mania, where you get crazy, psychotic, and walk down the middle of the street shooting off guns saying you're Napoleon, they're going to say, no, I don't have that. But if you talk about mild creative highs, you will pick up patients who have hypomania at the beginning or end of their depression, and most people who complain of recurrent depression indeed have hypomania as part of their illness. So it's not a very prevalent disorder, but since people don't do well in treatment, it's the kind of disorder that gravitates upward in the medical scale so that the patients get beyond the expertise of the local family doctor and the local psychiatrist and get to the psychopharmacologist and then finally get to the affective disorder specialist for treatment. So they cluster in certain settings. Is it any different than other forms of manic depressive illness? We asked that question and we looked at different populations in this. We had 33 patients. We broke them down into bipolar 1 and bipolar 2. The age of onset is not different compared to non-rapid cycling patients. How frequently do the attacks occur? Well, for a year was about half of our patients, but a number of them had 20 episodes a year or so. Now, 20 episodes a year, if you think about it, is a week of high and a week of low, or a week of high and 2 weeks of low. So they're sick most of the time, so that you can get patients who have very frequent attacks and are almost consistently cycling. The issue here is that there are a lot of people who present with rapid cycling mood disorders who probably don't have any of these conditions. And particularly in certain areas and among certain age groups, you're going to see patients who complain of my moods go up and down very quickly, and they're going to have psychoactive substance-induced mood disorder, which is seen in people who've had a history of abusing hallucinogenic drugs and people who are alcoholic. So that when I take a history from a patient and the patient says, I've been depressed all my life, I'm apt to start thinking this is not a primary illness, this is a secondary illness or some sort of characterological problem, because a primary affective disorder, patient goes along just fine and then gets sick. So they wouldn't tell you that. They would say, I was fine until I was 24 and then I got sick. The patients with psychoactive substance-induced OMS, mood disorder, say, I get high for an hour and depressed for an afternoon. And so they have these brittle mood shifts, and they don't last very long. And they complain of this constant mood fluctuating. And when I hear that, my next question is, have you ever used hallucinogenic drugs in the past, and how many times? And there's a real good correlation between past history of hallucinogenic drug use or alcoholism and that kind of brittle mood disorder. So what you see in the more solid mood disorders are episodes that last several days, and what you see in the characterological disorders and the drug-induced mood disorders are episodes that are quite brief in time. The patients seem to complain about the mood shifts more than you might think because of the severity of the actual symptoms. Is this cocaine withdrawal? Is this some other substance that's being used? I've seen this in patients who take marijuana every day and then complain of mood shifts, and my temptation is to tell them to stop the marijuana and come back in a month or so, and let's see if you're still having the mood shifts. Now, among the other things are dysthymic disorder, which is sort of this chronic sporadic depression that goes on for several years and can date back into childhood. And cyclothymic disorder is the same as dysthymic disorder. It's a chronic sporadic depression with brief highs, and the highs will last a day or two. So the way to get that history is to say, well, you've been depressed all your life. There's a condition called dysthymic disorder where you get depressed for several days with symptoms, but you don't get 2 weeks solid. It's sort of sporadic. It's a few days here and then you're okay, and it's a few days there and then you're okay. Is that what you're talking about? And the patient says, yeah, that's what I mean. I say, on the days you're okay, are you okay or are you up high, terrific, on top of the world, elated for a couple days? Then it's cyclothymic disorder. So both types can present as depression. Cyclothymics, their high moods often last several days, 2 to 5 days, let's say. Now, the reason I bring it up is that isn't going to respond well to any treatment known to mankind. It's not been well researched. They often get diagnosed as being rapid cyclers because their moods are shifting rapidly, but it's clear that they don't have the kinds of responses that you'd like to see with the primary bipolar patient because they're really different. They've really got a complicated illness. They've got something else going on. The other thing to think about is this a medical problem like an unstable endocrine system disorder? And those are the things that go through my mind when I hear about these brittle mood shifts. What happens with lithium? Well, for the most part, intermediate results. 4 patients treated with lithium for at least 2 years were well for at least a year, and that's pretty good. 4 patients didn't change. 8 patients showed a decrease in frequency of episodes, so rather than having 8 or 10 episodes a year, they went down to 6 or so, and then didn't change after that. And 1 patient didn't get better in year 1 and decreased in year 2. So these patients who were treated with lithium, because it offered a lot of hope for them, didn't do impressively well with lithium treatment. All right, lithium is useful, but it doesn't do everything you'd like it to do. If you're going to start a patient on lithium, you should have a pre-lithium workup, including a physical exam, CBC, because the white count is elevated, urinalysis to check on kidney function, thyroid tests on everybody, thyroid antibodies on rapid cyclers, and FSH levels about once a year, or if the patient seems to be having myxedema because of lithium, BUN and creatinine, and an EKG. One of the things we found in kind of an incidental way, because we know that lithium had an anti-thyroid effect, and we wanted to see who were the patients who got anti-thyroid effects from lithium. Rapid cyclers, here about a third of rapid cycling women had some anti-thyroid effect from lithium, and that was a very high percentage. And so we published this kind of just sticking out in the literature saying we don't know if anybody else could find it, but we did have a large sample, and we found it. And about the same time, a group at the National Institute of Mental Health had also found an association between lithium and thyroid abnormalities in rapid cycling patients. And the bottom line is this: if you have a patient who is rapid cycling, draw not only the usual thyroid tests, but also thyroid antibodies, because a fairly high percentage of those patients will have elevations in their thyroid antibodies. And in those particular patients, the addition of thyroid hormone to lithium may be of benefit. So step 1 is identify the problem diagnostically. Step 2 is to try lithium, and step 3 is to draw thyroid antibodies and add thyroid if you find the antibodies are positive. Step 4 is have the patients keep a daily mood calendar. Very simple thing, a piece of paper with the date on it and the mood being depressed, normal, or high. What you want to do is you want to see when the switches occur from depression to mania, and if they're predictable. In some patients, they're kind of predictable. So we developed this treatment paradigm of lithium with or without antipsychotic medication. That was our first recommendation. Try lithium alone. If that didn't work, try antipsychotic medication. Why the antipsychotic medication? Because antipsychotic medications early on were what we used to treat mania, and particularly the less potent drugs like Mellaril or Trilofan in small doses we found useful to kind of keep patients from going from depression to hypomania. And why the mood calendar? Because we wanted to predict if that patient was showing regular cycles, and some of them do, that next Tuesday they were going to switch from depression to hypomania, and on Monday or Sunday we wanted to increase the lithium and add more Mellaril to kind of prevent that high. So the goal of treatment is to prevent the switch from depression to hypomania. And the logic for it is that if you prevent hypomania, the depressions simmer down and eventually smooth out. Now, there are two problems with that. One is that there's a bad illness now from giving antipsychotic drugs to people, and that's called tardive dyskinesia. And so you want to avoid the use of antipsychotic drugs if you can in patients who are non-psychotic or who don't need antipsychotic drugs. However, I think that in this case, the patients probably do better on them than off. So I would try lithium alone, and if that doesn't work, you might want to try a low potency, low dose of an antipsychotic drug. The second problem with the antipsychotic drugs is neuroleptic malignant syndrome, which we've seen infrequently, but we've seen in some patients, and that's a sometimes fatal disease characterized by fever and sweating and stiffness and confusion, and certainly a bad thing to happen to a patient. So again, you want to avoid the use of antipsychotic drugs in the treatment of these patients. We felt that antidepressants added to rapid cyclers cause cycling. Other people, particularly Fred Goodwin and Tom Ware at the NIH, also feel the same. So that if you have a patient who's going from depression into a high, and if the high is what drives the illness, so once they get high, they're going to go into a depression again. What you want to avoid is that switch from depression into mania or depression into hypomania. And what you want to do is avoid antidepressants at that time, because antidepressants are going to drive the patient into the hypomanic state. And then they're going to have at least a little high, and then they'll have another cycle. So we recommend that you take them off the antidepressants. Now, that's hard to do with some patients because they complain about depression. Most of their ill time is depressed, and they're going to say, what am I going to do when I get depressed? And I think you have to say that your depressions last 3 weeks, and it takes 4 weeks for a tricyclic to reach good effective levels and be effective. By that time, you're out of your depression on your own, so that giving you an antidepressant is just driving the cycle, but it's not really treating your depression. Carbamazepine is a drug developed and studied not too well, but at least studied in rapid cyclers, and is shown to have maintenance effects in rapid cycling patients. You need to get blood levels of your carbamazepine, and you need to get white counts as directed in the PDR. Although the neurologists tend not to get them, I guess psychiatrists tend to get them, and the cost of getting all the labs is more than the cost of seeing me. But at any rate, I think that carbamazepine would be my second line drug. And I tend to combine lithium with carbamazepine. Nobody's really written a book on it. There is some neurotoxicity of the combination, but I feel that having two maintenance drugs on board is better than just one. Some people prefer to use carbamazepine alone. Most of the carbamazepine studies have come from Japan. Most of the studies there are confounded because the patients didn't get just carbamazepine. They got carbamazepine and lithium and thorazine and some other stuff, so that they weren't very clean trials. But it was clear that the carbamazepine was helpful to manic depressive patients. I think there's been a tendency to kind of use it as a first-line drug, and I'd suggest that that probably isn't proper, even for non-cycling patients. I think that lithium works very well in probably 80% of patients just by itself, and so you ought to start off there. And then if it isn't working in, let's say, 3 to 4 months, then add something, and I would add carbamazepine, because there is evidence that it's useful. And sodium valproate is another anticonvulsant that has a big black box in the PDR about liver disease associated with this drug, and it's also useful in some rapid cyclers. So that's a drug that also you need blood levels. I have a couple people on it, and I must say I'm not impressed, but that's my third line drug, and those patients have failed lithium, lithium plus antipsychotics, lithium plus carbamazepine, carbamazepine alone, and are now on lithium and valproic acid and not doing appreciably well, but they're awfully tough patients, and kind of winnowing out all the good patients as we go along. I mean, about a third of my rapid cyclers, I put them on lithium, and they come back in a week and say that they're all better, especially if they've never been treated, even though I told you they're hard to treat. Some of them just miraculously get better with a little bit of lithium. ECT is effective in mania, and ECT may be a useful treatment to kind of break things up if someone's cycling rapidly, to put them in the hospital, give them a course of ECT and start again. Now you need to stop the lithium before you use ECT, because if you give ECT while a patient is taking lithium, they can get some neurotoxicity that can be permanent. But I think that it's an underused treatment. An interesting drug that's not currently available. It's available in some places. Let me put it that way. It's available in Seattle because we have it. I know it's available in San Diego. It's a drug called Welbutrin. It was marketed by Burroughs Wellcome, or was to be marketed by Burroughs Wellcome. It causes seizures in patients if they take it too high a dose or if they increase the dose too rapidly. The company and the FDA got into a to-do about the package insert. The company decided not to market the drug. Patients who'd been on the drug wrote to their congressman and said, we want the drug back on the market. So the company is now doing a surveillance study to see how frequently seizures occur if you increase the dose slowly and if you maintain it not above 450 milligrams. Really, the seizures are not the problem with the drug if you give it in the correct way or to correct patients. Now, it doesn't seem to cause cycling, so that the antidepressants, and all of them, to my knowledge, cause cycling, especially the tricyclics, if they're given to bipolars, will induce mania. This drug does not seem to do that. We thought it might be a maintenance drug like lithium, and we tested it for that. And I don't think it does that. I don't think it's that good. But at least for bipolar patients, it doesn't seem to induce mania and may be a better antidepressant for them. Stimulants I don't think are useful for treatments for depression. Tricyclics will cycle patients. MAO inhibitors, it's not clear if they cycle them or not. There's an undocumented sense that they're better for the depressed phase of bipolar patients than tricyclics. It's not clear that they particularly cycle them, but there are drug interactions with this class of drugs that make their use somewhat problematic. Among the newer antidepressants, there was one released called Prozac. It's a Lilly compound. It can induce mania in bipolar patients who are depressed. We studied some bipolar 2 patients with Prozac and didn't find any mania from that drug. I think the story isn't in yet whether it's a good drug for bipolar depressives or rapid cyclers or not. It takes about 3 weeks to get adequate blood levels to start working, and so since most of the rapid cyclers don't have depressions lasting that long, I think it's probably not going to be very useful. Let me talk about light therapy for a second. These depressions don't last terribly long, and it may be that light therapy could be useful for treating the depressed phase, but there have been a few hypomanic reactions reported with light therapy. Light therapy is based on patients who have winter depression and who oversleep in the winter, and you give them a good dose of morning light, and it has some antidepressant effects in them. But there are hypomanic episodes reported, and so it's possible that light therapy might cycle the rapid cyclers. I'm not aware of any data on light therapy in rapid cycling patients. I like to get people into regular structure. Another thing I tell them to do is to put out a calendar and block out every hour for the next day with something to do, and include 2 blocks of exercise in that time, because I think it's very important that patients who have mood disorders structure their day so that they don't have a lot of time just to think about how bad they're doing. And particularly when they're in a hypomanic state, you want to clobber that as best you can, and so you raise the lithium dose and you raise the dose of other medication, and you maybe add some benzodiazepines to it, and you make sure the patient's sleeping well, and again you make sure the patient has a lot of activity, so that the idea is to take as much off the hypomania as you can. The shorter and less severe the hypomania, the less severe the subsequent depression. But if you just have a little high blip for a couple days, you're going to go into a little depression afterwards. And psychotherapy, I think, is important not only for the patient but for their families in this regard, because first of all, they have to realize that it's not today's illness that they're worried about treating. It's really the cycle that's going to continue over a long period of time. So you have to approach this in the context of a long period of time for treatment. Now, having an up and down illness like this can be very detrimental to families, to the patient, to jobs. Sometimes adaptive. I've known salesmen who worked kind of every third day because that was their hypomanic day, and the other 2 days they were depressed, and so they only worked on the days when they were hypomanic because they couldn't function on the other days. But by and large, to adjust to that kind of cycle is rather difficult for families and patients, and I think the first thing is to have them read a book called Mood Swing by Ronald Fieve, F-I-E-V-E. It costs around $3 in paperback. That tells them all about manic depressive illness and lithium and talks about rapid cycling. Tell them it's a long-term illness. Tell them that you're not going to get them better in a week, that you really have to plan treatment programs out for long periods of time. Tell them that it's better to go systematically, drug 1, drug 2, drug 3, than to keep switching drugs back and forth. That you don't gain anything by trying something out for a week and then switching to something else. Get them involved in the monitoring of their treatment so that, sometimes the patient will come in and will tell you one story and the spouse will come in and tell you a somewhat different story about the course of illness. And it's important that you have a clear idea of course of illness, because if you find a patient who's switching from depression to hypomania, that's the time you really want to jump on them if you can predict that switch. Try to keep them in some sort of constant day-to-day activity level, because I think it's useful for people, even when they're depressed, to kind of maintain their usual daily function as best they can. I think all of these things are in what I would call educational psychotherapy. There may be particular marital problems that develop around these issues, and that can be dealt with other kinds of treatment.
The next speaker, George Winukur, elaborating on treatment of bipolar disorders, focusing first on acute mania.
In lithium, you have the best data of all. They're open and double-blind studies, and you have an improvement in 68 to 100%, and it's very useful for prophylaxis, which is great because it's a relapsing illness. How good is it for prophylaxis? I don't think we have the final answer for that. It doesn't make them well indefinitely, although some patients, of course, do stay well indefinitely. But I'm not sure that you get a total improvement so that a high percentage of patients never have another episode. Neuroleptics are more effective than lithium in reducing the motor activity, and it is also useful for prophylaxis. Less effective than lithium in reducing mood and ideation symptoms. Now, the thing that's interesting about neuroleptics is they would be great treatments for patients that had bipolar illness if it weren't for that damn tardive dyskinesia. So you're unlikely to use it, but on an acute basis, that is probably the most useful drug. Now, in the old Prion study, which is the NIMH-VA study, neuroleptics were better for highly active, and lithium was better for the mildly active. And a combination seems reasonable at the time of admission into the hospital. Now, ECT is better than neuroleptics, and you could make a case, there would be a case you could make that you would give ECT to get over the acute episode in the most rapid possible way, and then follow it immediately by lithium. You could make a good case for it. I don't know what happens under those circumstances because I don't know anybody that's tested that specific thing. But that's worth testing. That would be a good study. Now, we're getting on to the other sets of things. Tegretol seems to have a poorer response than lithium, according to Lehrer and Gershon, but it may be relevant to some subgroup, and there may be some question as to whether it's good for prophylaxis. It may be. The study was done by Shukla and Brian Cook when both of them were at Stony Brook, and they used lithium plus a neuroleptic and lithium plus carbamazepine in the same patients, and the patients that were on lithium plus carbamazepine did better. And I think there is some reason to believe that carbamazepine is a legitimate treatment for mania. I think the problem is that it may not be as legitimate a treatment without the lithium together, but I don't think we know that for sure at this point. Okay, let me point out to you that there are some problems in terms of the clinical picture of treatment of mania. This is a large study that we did. 74% of uncomplicated manics, which are schizoaffective manic plus mania, get well with total adequate therapy. That's total adequate lithium or ECT. And if you give them inadequate therapy, they don't get well as much. It's 74.3% to 57.5%, which is in fact a statistically significant difference. But if you start looking at complicated manics, and complicated manics are those with other diagnoses, either other predisposing diagnoses or with medical problems, they not only don't get well as often, 42.1% and 47.4%, but it doesn't seem to make a lot of difference whether they get adequate or inadequate therapy. So that patients that have complicated manias complicated by such things as medical disease, other psychiatric illnesses, alcoholism, hysteria, anxiety attacks, all kinds of various, and they do badly. I hesitate to call them secondary manias because I don't believe such a thing exists. So I think the word complicated mania is probably the better one for that. Secondary depressions do exist. Okay, the new paper that just came out from the British literature, and this is subcaudate stereotactic tractotomy in the bipolar patients, and a lot of those episodes stop after you do it. Not all of them, but a lot of them stop. Now, none of us ever do that kind of operation, but I think it's something we ought to think about, although I don't plan to present it to you as a scientific verity. There is one study on clonidine which suggests efficacy. There is one study on clonazepam compared to lithium, and it looks pretty good. It was better on overactivity and talkativeness, no difference in mood, pressure of speech or insight. Of course, pressure of speech is overactivity, so I wonder how come it could be one and not the other, but that's all right. You know, anybody's entitled to make a decision about that. Sodium valproate and propanolol, that's been done in Germany a fair amount. Lithium and tryptophan by Chouinard has been reported. There have been a spate of reports on verapamil. Thiazide lithium combinations have been reported by Himmelhoff, spironolactone, ascorbic acid, methylene blue. All of these things have been presented. It's highly questionable whether any of them have been shown to work. But it gives you as a clinician something to do. I mean, your hands are really not tied. And if you do it for long enough, you're sooner or later going to be successful, because it is a remitting illness, although it remits a lot and it exacerbates a lot. This is the methylene blue study, and Naylor figured out a way to blind it. He gave some of them 300 milligrams a day and some of them 15 milligrams a day, and of course they all had blue urine. And you do see some differences after a period of a couple of years. The people on the high dose had less weeks ill, they had less weeks depressed, their morbidity index was lower. Unfortunately, the manic score wasn't lower. It seemed to prevent some of the depressive symptomatology, but not the manic symptomatology.
And that ends Side A. Dr. Winukur concludes on Side B. This is Side B, Audio Digest Psychiatry, Volume 17, Number 12, continuing a program on mood disorders and rejoining George Winukur as he reviews additional findings pertaining to pharmacologic treatment of bipolar illness.
Verapamil is much better in terms of reducing the manic rating scale in the BPRS than the placebo was. Chouinard's study on clonazepam was better for motor overactivity. It was better for elevated mood. Now, people say, well, what do you expect? It's a sedative. I don't think it makes any difference what it is, I mean, if it works. The problem is that it's never been used very often. The problem is that we don't know whether it works, because this is, as far as I know, the only study where people have attempted to look at it. That's another one that I think is worthwhile looking at. Here's my favorite study of all of them. Why is it my favorite study? Because Nelson Hendler, when he was at Johns Hopkins, put 6 patients on spironolactone. These patients did not like taking lithium. And he gave them 25 milligrams QID, and at the end of 1 year, 5 of the 6 patients had remained well. And I thought, that is one of the great ideas of all times, except for a little breast enlargement in men. It shouldn't be any problem to put people on spironolactone. But the problem is that nobody has ever taken it up, and I've never seen a second study that's been done on spironolactone. I once heard Moen Scow give a talk, and he talked about using it. And I talked to some of the people at the NIMH, and they implied that it didn't work, but I don't know where the data are to indicate that it didn't work. That's one of those other studies that I think might be kind of worthwhile to look at. Lecithin, this was done at McLean Hospital. On placebo, the manic patients did less well than they did on lecithin, 10 milligrams TID. Once again, that's the only study that I know of that deals with that. Interesting. The idea is rather similar. It's the idea that you give physostigmine to somebody who has mania and makes them depressed, and it gets rid of the mania. So you're giving a cholinergic drug, and you're trying to do the same thing. Himmelhoff and Detry and Kupfer, when they were at Yale, found that patients that had bipolar illness had energic depression with motor retardation. And finally, Himmelhoff did a blind study. And he compared parnate and imipramine, and he found that the parnate was far more effective than the imipramine. so that the Parnate lowered the Hamilton rating scale by 20 points, the imipramine by only 5 points, and I would be inclined to suggest that's probably a good idea to try patients on Parnate. I might say parenthetically that I do have a professor of psychology who was on Parnate for years. It seemed to work in the beginning. It stopped working. I took him off the Parnate and put him on Nardil, and he's doing fine again on the Nardil. Now why? I have no idea. And is that science? No. That's clinical treatment. But it's worth thinking about anyway. The point is this: there are very few decent studies of the treatment of mania or bipolar depression. By and large, you're stuck with the studies that tell you that ECT works, lithium works, neuroleptics work, and Tegretol is worth considering. The rest of them are very interesting, often imaginative, often promising, but need to be tested.
The final speaker, Alan Schatzberg, with some findings and recommendations pertaining to affective disorders in the elderly.
Affective disorders in the elderly are a major problem, one that, as clinicians, we see all the time, and one which affords great opportunity, I think, to provide help for many patients. I think, just to clear up misconceptions, depression in the elderly is not the usual state of affairs. Becoming older does not mean one necessarily becomes depressed. Certainly, the vast majority of older individuals in our society are not depressed and function well. And increasingly, as people maintain their cardiovascular training and condition, one finds vigorous individuals in our society who are not depressed and hopefully will never become depressed. Really, if you look statistically at epidemiological surveys, in fact, today, most individuals who are over the age of 65 or 70 are vigorous and do not suffer from a mood disorder. But when one sees a mood disorder, or when one sees an individual is depressed, one needs to try to look at the causes as well as what are the modes of intervention that are available for these individuals. So it's important not just to ascribe a lowered mood and classic neurovegetative symptomatology of depression to the aging process. Now, there are issues, though, I think, in the aging process. They have to do with the question of whether the elderly are more prone to stressors and to environmental stress than are younger individuals. And such stress may play important roles in the development of specific psychiatric symptomatology. That, I think, is part of growing old. One of the first early studies of the population was done by Gerland about 10 years ago in the Washington Heights area of Manhattan. And they did a rather comprehensive, sophisticated study at that time. And when they looked at the prevalence of significant depressive symptomatology in their routine survey, they came up with a prevalence of about 13% in terms of pervasive depression in a so-called normal population in Washington Heights. I think if you look at the more recent prevalence rates, they're considerably lower. I think this has to do with what one terms depression. At one point, the notion was that suicide peaked in women around 65 and then dropped off and continued to rise in males. It is not entirely clear whether that really is the case. Some recent data suggests that, in fact, there may not be as much of a plateau in female suicide as had been originally reported. At any rate, certainly increasing aging in the male seems to be associated with greater prevalence of depression, and certainly these individuals do have relatively high suicide rates. One of the things that Gerland did was look at individuals who are on psychotropic medication, including hypnotics, to look at the percentage of individuals who were depressed, and what you found was that almost half of individuals who were taking drugs, particularly hypnotics, showed depressive symptoms. So that these individuals do go to physicians. They are often given sleeping pills rather than antidepressants, and this presents a problem because these medications may not really help their underlying illnesses. One of the things that came out of Gerland's study was that there was a relatively high prevalence of seemingly organic impairment in terms of dementia or confusional episodes or confusional presentation, with prevalences of around 5% and higher. These numbers, I think, are a little high, but they do point out that there are a significant number of individuals who do show some form of cognitive impairment, whether in fact this is really always due to dementia or cardiovascular problems rather than depression, really I think needs to be evaluated. How does one tell the difference between pseudodementia and dementia? Well, I think still in psychiatry this remains the most difficult differential diagnosis, one that many workers have described, but in the end one is often stuck with a very difficult differential diagnosis, and my feeling is that if you at all suspect depression, one ought to go ahead and try and treat it because the downside risk is low compared to the potential upside gain. But one of the things that one looks for in clinical course and history, in pseudodementia of depression, the family is quite aware of the impairment. They can usually tell you when the person started to go downhill. The symptoms may be of relatively short duration before the help is sought and with a rapid progression. And they may have a previous history of depression, not uncommonly. In dementia, it's more subtle, it's more incipient, where the family may be often unaware, cannot really date it. This may be going on for a long time with some forgetfulness and without an acute onset. And these individuals may less commonly have a previous history of depression, although obviously the absence of a previous history doesn't tell you all that much. Individuals can have late onset depression. The previous psychiatric depression, I think, should be a tip for thinking of recurrence of a depressive episode. The complaints: the depressed pseudo-demented patient will complain more of cognitive dysfunction. He will talk about his disability, can't concentrate. At the Beth Israel in Boston, they have an adage: if a patient comes in and complains of a memory loss, by definition he doesn't have Alzheimer's, because these individuals usually are less aware of it. And patients generally who are complaining of memory problems will frequently be depressed. They will communicate their sense of distress. They will show incongruent behavior to the severity of the cognitive dysfunction, and they often will not show this nocturnal sundowners type syndrome. The demented patient usually complains less of the cognitive loss. Other people seem to know it more, and they're vague about it. They will sometimes try to hide it. They later on can be almost silly in talking about their accomplishments, but they need a struggle to perform tasks, and generally they will show less in the way of the depressed affect and more in the way of denial and being unconcerned about their illness. These individuals may more commonly show a nocturnal exacerbation of their cognitive dysfunction and confusion. The clinical features: the pseudo-demented patient may give don't-know answers on orientation. The memory loss for recent and remote memory may be equally severe. Generally, I think the pseudo-demented patient tends to have more problems with recent memory and learning and has pretty good remote memory. In fact, they will come in more with, I can't remember whether I'm taking my medicine, whether I eat breakfast, etc. And there is reasonable variability in performance, so it's not across-the-board decrement that you start to see with particularly later demented patients. The demented patient will show you more near misses on orientation tests. They will mistake the unusual for the usual, sort of faking it, if you will, in quotes. The memory loss for recent events may be more severe than it is for remote events. And I've found that this recent versus remote memory, in my clinical experience, has not been that helpful to separate pseudo-demented and demented patients, as Wells reported several years ago. When you really get down to it, it's very tough to tell the difference, and it's a differential diagnostic problem that we face all the time. If you look at the ancillary diagnostic tools available for evaluating such patients, including skull x-rays, in the old days, neuroexams, EEGs, CAT scans, etc., you get a lot of false positive with many of the CT scans. You get a lot of people having large ventricles. It doesn't tell you all that much, and you get a lot of false negatives as well. And it is really quite difficult. And I think in the end, if you're at all feeling that the individual may be depressed, I think one ought to go ahead and treat them for their underlying illness. The real question comes, how far does one go? And generally, it gets to the point of whether one needs to or should give the individual ECT. And my feeling is that one ought to give ECT to such individuals if the impairment is pronounced and there's any suspicion that the individual may suffer from a severe depression, particularly the diluted type. Bipolar elderly patients present a particular problem, I think, for psychiatrists. I think the work at Himmelhoch about 5 years ago clearly shows that late onset bipolar illness in individuals really generally is due to some form of organic impairment, either a cardiovascular problem with impaired or compromised vascular flow to the brain, some strokes, or a metabolic condition. So if you see late onset bipolar illness, look for underlying medical or neurological conditions. In the same vein, such individuals are relatively poor responders to lithium carbonate. They often will become toxic on lithium carbonate. And John Himmelhock a few years ago reported a nice series of such individuals who were better controlled on carbamazepine or Tegretol than they had been on lithium carbonate. Now, what are the common medical causes of depression? And these occur in the elderly as well as in younger individuals, particularly the cerebrovascular impairments. One of the things to keep in mind is that older individuals can show hyper or hypothyroidism. We had just recently an individual admitted with a severe depression who on workup turned out to have an elevated TSH and pronounced elevation in thyroid antibodies and probably a secondary depression to that. He did not complain of the usual symptoms of either hyper or hypothyroidism. Remember also that about 15 to 20% of individuals with increased T4 and increased thyroid output look hypothyroid on clinical presentation, so-called paradoxical presentation. And one needs to, I think, evaluate thyroid function in individuals of all ages, including the elderly. Hyperadrenalism, my feeling is, and I think the feeling of others, is that the hyperadrenal output of elderly individuals may, in fact, lead to impairment in a variety of functions, and one I think that one needs to keep in mind in terms of looking ahead at what may be the pathophysiology for some important illnesses. The hepatitic disorders, collagen disorders, etc. can occur in the elderly as well as young individuals. One thing I think that does occur is this drug-induced syndromes due to antihypertensive, particularly alpha-methyl-dopa. I've had at least 2 people in the recent months, over 60 on alpha-methyl-dopa, come in with pronounced depressive illnesses and really did better when they went off. We don't see that much reserpine-induced depression. Years ago, when the reserpine-induced depressions were described, and this was one of the first kind of planks in the so-called psychopharmacologic bridge of depression, reserpine was being used at about 4, 5, or 6 times the current recommended dosage. So that nowadays, when people use reserpine, you tend to see less depression, I think, with it, although obviously it's used a lot less than it used to be. Now, what about the treatment? Well, we all know about the tricyclics. These tertiary compounds, anafranil, clomipramine, amitriptyline, or Elavil, or imipramine, are metabolized to a demethylated metabolite. These demethylated metabolites are primarily noradrenergic and reuptake blockade, and they are less serotonergic than are the drugs like amitriptyline, nortriptyline, and anafranil. Now, in fact, amitriptyline and anafranil, etc., these drugs are not all that serotonergic. These are very weak serotonergic agents in comparison to the new classes of drugs that will be available over the next 1 to 3 years. The so-called serotonin reuptake blockers are a much different kind of drug, and they really work very, very differently and are much more potent in terms of their serotonin reuptake blockade. What's particularly important in looking at the tertiary versus the secondary properties is that the tertiary compounds tend to be more anticholinergic, and they tend to produce more in the way of blood pressure effects, particularly hypotension, than do the demethylated metabolite. Secondary means may increase blood pressure slightly, so that if you have in the elderly particularly, so an individual who gets hypotensive on drugs like amitriptyline or doxepin, and as a rule of thumb, I think the old adage of start low and go slow is a good one, particularly in the elderly. But if you have someone who can't tolerate imipramine, try nortriptyline in low doses, because nortriptyline tends to be tolerated better in terms of the hypotensive effects. It tends to give you less orthostatic hypotension, particularly at the usual therapeutic dosages, than does imipramine. One thing we were struck with, and recently we did a study, Eric Dessain and John Kohler, myself, on surmountable trimipramine versus imipramine in individuals over 55. And we thought the 2 drugs would be equal. Surmountable is a drug that's been around a long time, but it's somewhat sedating. It's a little different than imipramine. And what we found strikingly was that in the elderly, individuals tolerated surmountable much better than they did imipramine. They had no hypotensive effect. They had no tachycardic effect that you do see with some of the antidepressants, particularly the demethylated compounds. And in fact, they slept well in the first week. By the end of 4 to 6 weeks, we had fewer people drop out on surmountable than they did on imipramine, and the 2 drugs at that point were equal in efficacy. So the drug turned out to be a good antidepressant, but it turned out to be much better tolerated. Average dose was about 50 to 75 milligrams per day. So that I think surmountable may turn out to be a very good drug for the elderly. It's highly calming, people sleep relatively quickly, and you get much less of the cardiovascular effect, and you get much more of a sedative, hypnotic type effect than you do with nortriptyline. which can be tolerated okay, but in and of itself has problems in terms of its not being sedating and calming particularly. Now, the MAO inhibitors, we have in this country really 3 drugs that are commonly used as antidepressants: phenelzine or Nardil, isocarboxazid, or Marplan, or tranylcypromine parnate. Nardil and these drugs are very good antidepressants in individuals of all ages if you give enough medication. And in fact, people have to be given enough phenelzine. If they are, they do quite well, and including the most endogenous depressed patients. Although we think that the MAO inhibitors probably would be very risky in the elderly, in fact, Georgatos has done some very elegant studies at NYU showing that Marplan is a very good antidepressant in the elderly, particularly those who don't respond to drugs like nortriptyline or other tricyclics. And he's taken a whole slew of these individuals and treated them double-blind with Marplan versus placebo. And even individuals who were on antihypertensives did relatively well on Marplan. It really worked quite well, and it was effective, and it was reasonably well tolerated. He had very little problems in these individuals. And now there's a study recently came out, I think, in biological psychiatry from John Davis's group, I think looking at Nardil, showing the same kind of effect. So in the elderly, if you get stuck and tricyclics don't work, one option is the MAO inhibitors. I think you have to watch the patient because these drugs can be hypotensive, etc., but these are a reasonable option even in the elderly, and something to keep in mind. One of the things I think that we've noticed, there was, I think, a letter to General Clinical Psychiatry or someplace that using procardia might be helpful in terms of hypertensive reactions to the MAO inhibitors. And in fact, we've been giving individuals scripts for 10 milligrams. John Cole recommended this, and I started doing it. And giving people 10 milligram pills, give them 10 or 15 to carry around with them, so that if they get a hypertensive reaction, they can take one. And nifedipine or procardia is something to really keep in mind if you're going to use MAO inhibitors. I've started doing it routinely now. Now, there are a lot of selective serotonergic antidepressants that are different than the tricyclics. And I thought I'd talk a little bit about today trazodone, if I could, and fluoxetine. A number of others. Clomipramine is marketed outside the U.S. Maybe it will be marketed in a few years. Melodine has now been taken off because of a number of severe allergic reactions and deaths. It's been withdrawn worldwide by Merck. Fluvoxamine and sertraline are 2 drugs that are under active study and will be probably on the market in 3 or 4 years. These are considerably far away from the market, although they're very, very promising drugs. Now, these drugs, if you look at their relative potential for blocking the postsynaptic acetylcholine receptor, particularly the muscarinic receptor, amitriptyline and doxepin are far more anticholinergic than trazodone and fluoxetine. Trazodone and fluoxetine are very weak anticholinergic drugs. If you look at the antihistaminic effect, they have very little antihistaminic effect, so they seem to be quite different. The alpha-1 effect, fluoxetine has none. Alpha-1 effect is a postsynaptic norepi receptor, probably involved with the control of blood pressure, so that here for amitriptyline you're more likely to get hypotension than you will with trazodone. Trazodone, though, will give you hypotension if you take a lot of it on an empty stomach, because you get a sudden bolus of absorption and a sudden alpha-1 effect. Fluoxetine has virtually no blood pressure effects. Now, if I could say a few words about trazodone. You got to remember the package insert says start at 150. I find very few people can take 150 milligrams of trazodone per day, and I've never used it in that way. There is a notion, and there has been a notion, that trazodone has a window, that if you give too much, in fact, the response rates are lower. Now, it's been a difficult thing to demonstrate, but in fact, I think that there are some things to suggest this may be the case. And this may be the case for drugs that are generally serotonergic. This comes up not only with trazodone, but comes up with fluoxetine. So that my hunch with a drug like trazodone, even beyond the question of the elderly, even in younger individuals, one needs to develop a strategy where one starts a lot lower, aims for lower dosages, and if the individual doesn't respond after several weeks, then perhaps push up. I rarely go up much higher than 200 to 300 milligrams in this drug. I think I get better results at 100, 150 than I do at higher doses, and I think at lower doses the drug has more efficacy than we thought. I think the notion that it doesn't have efficacy cannot be supported by the double-blind studies. I can give you an example of why I think in clinical sense this is true. If you look at the mean dose in terms of prescriptions that people use in the community for trazodone, now some of this admittedly is being used as a hypnotic, it's relatively low. People are using it clinically at much lower doses than the company marketed at. Now, fluoxetine is a very interesting drug made by Eli Lilly. It is a pure serotonin reuptake blocker. Overall efficacy in these studies is as good as the tricyclics and certainly better than placebo. The drug looks reasonably active and looks very similar to doxepin in terms of efficacy. What are the side effects? Well, again, we were taught these drugs are going to be sedating, right? Serotonin reuptake blockers. No, the biggest problems you have with them is that they cause nervousness in some individuals. Get really kind of tense, almost akathisic-like. A certain percentage, about 20%, 25%, will have mild nausea. They can have some insomnia. But they have very little in the way of dry mouth, relatively, drowsiness. Occasionally somebody will become drowsy, but generally much less drowsiness than with the tricyclics. You do not get much blood pressure effect. These are reasonable drugs to try. The elderly can tolerate them reasonably well if they do not get too stimulated because of the side effect profile. In terms of risk of suicide, it's very similar to Deseril in terms of, there have been a couple of deaths, but it's generally in individuals taking a lot of ethanol, diazepam, phenobarb, etc. So it's very similar to Deseril. Now, the dosages. The drug will be recommended in the following way. 20 milligrams for 3 weeks in the non-geriatric patient. And in the geriatric patient, I think they'll have the same indication, with a maximum of 60 milligrams per day. But they are going to recommend staying with the drug for 3 weeks at 20 milligrams. This is going to be, I think, a rather important and difficult issue for us to kind of deal with as psychiatrists. The half-life of the demethylated metabolite of fluoxetine is 5 days. It's a very long-acting compound. And in fact, the drug accumulates, and individuals require relatively low doses. There's a study that Montgomery recently did where he gave people 60 milligrams per day for the first week and then 20 milligrams once a week thereafter, and found that the drug worked pretty well. It's very long acting. So that in fact, this drug is going to be very important. And in fact, as you get higher, you don't get more efficacy. You start losing efficacy. If you go to 80 milligrams, it's even less effective. There are individual patients who will require 60 to 80 milligrams per day, but by and large, lower doses do better than higher doses. And I think this is a very similar thing to Deseril. So the serotonin reuptake blockers, I predict, will turn out to be really low dosage drugs, and ones that I think we're going to have to be very careful of. It's going to be rather different than treating with the tricyclics, although there are always individuals who need higher doses. One of the things that people have done, Ron Phoebe did, Reimher did with Bernie Grosser in Utah, is look at predictors of fluoxetine versus either placebo or imipramine. And fluoxetine looks as good as a tricyclic in individuals with no prior treatment, a typical course, episodic illness, etc. But it looks better in the people who have shown prior refractoriness. This drug does work differently than tricyclics. It's not just a tricyclic. And because of that, I think it does offer an opportunity for helping individuals who cannot either tolerate tricyclics or MAO inhibitors or who haven't responded. And I think this is the first step forward we've had in terms of a major agent in about 4 or 5 years. The last point about this drug, there's been a lot of excitement because the drug does not cause weight gain. It tends to produce weight loss, so even in younger individuals, this is going to be a very good drug for people who have shown pronounced weight gain on tricyclics. They may not lose a lot of weight on it, but you tend to see less weight gain. Now, none? No. We've seen people gain weight on it. But in fact, generally speaking, this drug does better. And I have one bulimic patient who really has lost about 40 pounds on it and is very happy, and she's been on it for about 18 months. But we've had the drug up our way for studies and for compassionate use for about 2 or 3 years, and we've been satisfied with it. It's a reasonable drug if you get by the jitteriness. If you see the jitteriness or the nausea, cut the dosage down. 20 milligrams once every 3-4 days, and then build up more slowly.
And that concludes this edition of Audio Digest Psychiatry, published twice each month by the Audio Digest Foundation, a non-profit subsidiary of the California Medical Association. This tape is copyright 1988.